I'm going to start on the pathology report and the dermatoscopy report. You know, what you need if you're going to do these, you need a good microscope. And I've put Cliff's up there because mine's modeled exactly on his, with a nice Olympus that's a reconditioned microscope. And that's a great way of getting them. Find out who does the microscopes for the path companies that you deal with, and approach them and see if they've got a reconditioned one, because they're still superb. You need a good camera stuck in the top there. That's a Canon 50D. It's a bit older now. And that will allow you to put any of the images you're seeing with your microscope onto your computer, and you just click a button and you can photograph any slide that you in fact get back. And I'd certainly urge you to get pathology slides from your pathologist and learn to look at them as well. You need a dermatoscope as well. If you're pathologists here, those are dermatoscopes. A lot of this presentation is going to be for both GPs who are learning dermatopathology, and the dermatoscopy is going to be for the pathologists that are here. And there's quite a bit of similarity. You know, you've got patterns, colors, and structures. And in DermPath, the patterns are 7 patterns of inflammatory skin disease. We're not going to go through these. Clay's written an excellent textbook on that if you really want to look at that. But we're mainly going to concentrate on tumors of the epidermis and the dermis and the structures that are therein. And you know, in dermatopathology, they look at colors, the colors of blue and pink, and that's hematoxylin and eosin. The blue color is due to the hematoxylin. It stains up nuclei. So that's why all the cells, whatever they are, look blue, because it's staining up the nuclei. It also stains up the granules in the stratum granulosum, and it will stain up calcium, and it looks a bit blue too. And you'll see some slides later that have got calcium in them, and they'll be stained blue. The eosin stains up any intracellular protein or extracellular protein. So all your collagen and the like will show up pink in H&E slides. And there are a lot of special stains in pathology for other things. And the structures in dermatopathology, it's basically the cell types and their organization. And these are all the various cell types that we in fact have. And so you can see the range of dermatopathology that we may have. Dermatoscopy is the same: patterns, colors, structures. Here the patterns are repetition of the basic structure. The colors are black, brown, gray, blue, white, and pink. And most of the black, brown, and some of the gray and the blue, it's related to melanin pigment. But you can get pigment from blood as well, pigment from keratin and collagen, and sometimes that'll add an orange pigment to some lesions as well. And our structures, though, for the pathologists that are here, are these things. And we'll come back to those in a minute. With the pathology report, when you send information in, you give the patient's name, the date of birth, and the site of lesion. And that's important to the pathologist, certainly the date of birth and the site of the lesion. And we'll explain why that's important. The name's also important, especially if it's got doctor in front of it. So I'm sure pathologists do look. It reminds me of when I was a medical student, and I was at a tutorial, and the consultant put an x-ray up. And he said, "McColl, what's wrong with that patient?" And I looked at it and said, "He's got lung cancer, sir." And he said, "That was taken 7 years ago. What do you think's happened to the patient since?" And I said, "He'd be dead, sir." And he said, "Look at the name on the x-ray." And I looked at it, and I said, "Oh, it's the same as yours, sir." And he said, "It is mine." He said, "Are you going to change your diagnosis?" And I just looked at him and said, "No, sir." He's clicked me and sent me away. So, you know, names can be important. This is the other information that you'll see on any path report, and it's important to, in fact, look at it. In the description, when you're getting that path report, it'll talk about the tumor, where it originates. It'll usually describe the cells. It'll describe the depth, clearance margins. It'll also tell you if there's any nerve, lymphatic, or vessel involvement. If you see any of that in a path report, you know, your ears should prick up and you think, whoops, this isn't going to be good. And melanocytic lesions have a lot of other described parameters, and we'll certainly talk about them. I just want to swiftly run through some tumor terminology, because you're going to hear some of these words today, and these are some of the ones I want to go through. Orthokeratosis and parakeratosis. Orthokeratosis is that area of keratin, that basket weave pattern. That's normal for keratin on the surface of the skin. When you've got proliferating lesions, or malignant lesions, some keratinocytic lesions, you get parakeratosis, and that's where the nuclei are still in that keratin. It's often layered like that. So when we talk of parakeratosis, it usually means a hyperproliferative lesion, and the nuclei are retained within the stratum corneum. Acanthosis. You know the terms, large cell acanthoma, things like that. Acanthosis just means thickening of the epidermis. And it can be due to hypertrophy or hyperplasia. And the one on the right here is the pathology of psoriasis, where it's due to hyperplasia. There's an increased number of keratinocytic cells there. And you can see some parakeratosis as part of the scale above. So there's acanthosis there due to hyperplasia. Acantholysis is another term you hear. And that's where you get splits occurring in the epidermis itself. And you can see these splits here. You can get acantholytic solar keratoses, acantholytic SCCs. It doesn't mean that it's any different from usual. It doesn't have any difference in prognosis or anything else like that. So acantholysis is a term that you hear. Grenz zone is when you have a clear area like this underneath the epidermis. This is your dermis. This is a cellular infiltrate here in a tumor called granuloma faciale. And there's this Grenz zone, a clear area where the cells aren't going. Architectural and cytological atypia is an awfully important thing when you're looking at melanocytic lesions. An architectural atypia refers to the normal things that are there, the normal nests and what have you, but the arrangement of them, how it's changed. And you can see, looking at normal skin there, this is from Cliff Rosendahl, and then as it goes to an in situ melanoma, you have nests that are haphazard, and as it becomes an invasive melanoma, it's much more haphazard, so it's much more architectural atypia, and Cliff would call that chaos. Cytological atypia is the atypicality of the cell itself, and you can see there's three examples here. There's the top one there that's showing the two nuclei in the excess eosinophilia. There's the other cell, the second one there, showing the large nucleus. And there's a bottom one there that's described, even though that's in part of a nest of melanocytes, it's described as an epithelioid cell because it's like cells in the stratum corneum. So this is cytological atypia as against architectural atypia. Apoptosis and mitosis. Apoptosis is programmed cell death. Cells can die in the epidermis if lymphocytes come in and attack them. But there's programmed cell death. Tumors, basal cell skin cancers have a lot of apoptosis. If you didn't, basal cells would expand enormously. But there's a fair degree of apoptosis where cells that are growing are suddenly dying again. And when they become apoptotic, you get these pink residue left of the actual cell. Mitosis is, of course, the opposite. Mitosis is where cells are, in fact, growing and dividing, and mitosis is obviously very important in melanocytic lesions in the reports we get from that. Our ears prick up if we're getting a report of excess of mitoses. Here's a nasty term, atypia and dysplasia. Something's atypical if it's non-standard, varying from normal. But some people like to use that term as dysplastic. It's just atypical. And of course, we use this dysplasia term when we talk sometimes about the cells, the cytological atypia of some cells in dysplastic nevi and obviously in melanomas. Pagetoid spread, you're going to hear that a lot this weekend. This is the upward spread of often clear-looking cells in the epidermis. And they're not just melanocytes. You can get other cells that will show pagetoid spread. Extramammary Paget's and mammary Paget's disease, that's where the name came from, is an intraepidermal ductal carcinoma if it's a mammary Paget's. And that just shows these clear cells in the epidermis. But of course, some people associate pagetoid spread of melanocytic lesions as meaning it's a definite melanoma in situ, and it isn't. And you'll find out about that as we go along as well. Lentiginous proliferation, and this isn't the greatest example, is where you have melanocytes proliferating along the basal layer of the epidermis, often as single cells rather than as nests. And Jeff has presented many lentiginous type melanomas, which is only that early change of spread of atypical melanocytes just along the base of the epidermis. Melanophages, these are these phagocytic cells that will phagocytose melanin if there's been damage to melanocytes or to the basal layer of the epidermis. And we sometimes call that pigment incontinence, but that's melanophages. And dermal fibroplasia, if they talk about that in, say, dysplastic nevi or in prurigo nodules, what they're referring to is that thickening of the collagen there in the upper parts, that pink layer of the collagen. That's dermal fibroplasia. Papillomatosis, if you hear of that, that's where the dermal papillae are extended up into the epidermis, and often you get marked overlying hyperkeratosis, and that's the histopathology of a wart, with a papillomatous surface. Metaplasia is where something abnormal, something you wouldn't expect to see in tissues at that area, is in fact found. So this is bone that's being found high up in the dermis here in skin. So that slide's showing metaplasia, and atypical tissues is in that area. Kamino bodies we want to mention. There you'll see these in Spitz nevi, and they're again these sort of pink areas. And you may think there's a lot of pink areas that we're sort of seeing. We've seen apoptotic areas, the cells that are pink. We've seen Kamino bodies that are pink. And I'll show you another one that's going to be pink in a minute. Keratinous cysts are lined cysts with keratin in them, and they're part of, say, milia. But you'll also get keratinous cysts like this in a trichoepithelioma. Clonal proliferation is where you've got keratinocytes, but it's a different, they look morphologically different to the other keratinocytes in the epidermis, and they'll say that's a clonal proliferation. Doesn't mean to say that it's malignant or anything like that at all, but it's just another morphological variant of the keratinocytes there. And this one, a coronoid lamella, you'll see those in porokeratoses. Of disseminated superficial actinic porokeratosis, the little castle, the little rampant of epidermis around the outside of the lesion. It's made up of this thing, the coronoid lamella. And you can see the parakeratosis there. You can see the little nuclei, the retained nuclei within that bit of keratin. But that's what makes up that outer little castle in a DSAP. Dermoplasia, or desmoplasia, I should say. You'll hear of desmoplastic, lots of things. And it just means thickening of the collagen in the dermis. So you can have desmoplastic nevi, you can have desmoplastic melanoma, you can have desmoplastic SCC, desmoplastic BCC, but it's just gross thickening of something induces the fibroblasts in the dermis to produce excess collagen. And so you'll get a lot of pink collagen like that in the dermis. And often you'll have just little threads of cells going in between those thickened areas of dermal collagen. And dyskeratotic cells, that's again, look at the pink cell that we've got there for a dyskeratotic cell. It's abnormal keratinization in some keratinocytes in, say, Bowen's disease or the like. They'll describe some of the cells as being dyskeratotic, and they're pink like that. Basiloid induction. See how at the base of this epidermis here, this is overlying a dermatofibroma. You might get a report back sometimes that says it's a dermatofibroma, but there's a BCC in the surface. It isn't. It's in fact a phenomenon that can happen with some dermatofibromas. They induce a change in the basal layers of the epidermis, and they proliferate like this, giving you a sort of pseudo-BCC. And then this one on the right-hand side is a storiform pattern. When they talk about DFSP, dermatofibrosarcoma protuberans, when they describe a storiform pattern, it's that interlacing of the spindle cells that you see in a DFSP. They call it a storiform pattern. Lichenoid infiltrates, it's that hard, that thick layer of lymphocytes there, up hard against the epidermis. And you see that classically in lichen planus. But it's the same thing that you'll see in LPLKs. It's a lichenoid, it's an immune reaction of T-cell lymphocytes hard up against attacking normally the basal layer of the epidermis or structures in it. Solar elastosis you'll see and hear a lot about. And that's that bluish material there underneath your epidermis. These are extensions of the epidermis, of the reti pegs here with pigmentation at the base, and that's an overlying solar lentigo. But it's this blue stuff here is the altered collagen, and we call that, and the elastic tissue, and we call that solar elastosis. So that's a brief overview of terms as far as dermatopathology is concerned. You'll hear these mentioned, and I've no doubt lots of things like lentiginous spread and pagetoid spread will be extrapolated on by various speakers. If you look at dermatoscopy, and this is for the pathologists that are in the audience that want to learn some dermatoscopy, and I'll go through this quickly because the vast majority of you will know all of this. Again, patterns, colors, and structures. And you should be now sending a dermatoscopy report to your pathologist. You should be telling him, and it may take the form of a diagram of the lesion that you've in fact sent. It may take the form of a photograph when you've photographed the dermatoscopy, or just a word description. And normally you'd probably put in the differential diagnosis, and specifically this last bit, any specific sectioning requests, because you know where the suspected change is in a pigmented lesion from looking at it with your dermatoscope. But the poor pathologist often doesn't know. So it's useful, I think, a photograph and showing can allow the pathologist to cut up in the areas that you're most interested in. These are all the terms that we use, of course, in a dermatoscopy report. And I want to concentrate on, this to me is the most important little slide that we may show in dermatoscopy. And that's how a network is in fact formed. You're looking down with your dermatoscope at right angles here. If you've got pigment in cells in the retiridges here, then you'll see layers of pigment if they're here. Now, that pigment doesn't have to be in melanocytes. It can be melanin in keratinocytes. And if you've got a whole layer of them there, that'll still give a line structure. And of course, if you've got big nests of melanocytes in there with a lot of pigment, you're going to have big, thick lines. And of course, in melanoma, you get proliferation of your melanocytic nest, thick nest, a lot more pigment, so your lines are a lot thicker in melanoma. This hole in the middle of the net is because you've only got a thin layer of pigmented cells there, and you're just looking through one layer at a time. So say you see an inverse network. You'll see an inverse network if all the nests are in fact up here in the papillary dermis. If that area there is filled with nests of melanocytes, and they're not, and the retiridges round about are relatively thin, then you'll get an inverse network where it's the central area that's hyperpigmented because of those nests of cells in the epidermis. And you'll get the line is going to be a clear line round the circle is going to be a clear circle around the outside, simply because there's not as many nests there. All the nests are in fact in the dermal papillae. And if you think about that, all the other structures and the like that you see because of pigment are in fact due to pigment in keratinocytes in that epidermis. And depending on how those keratinocytes are layered on each other, becomes the various other lines and structures that you may in fact see. So remember that picture. I honestly think if you know that picture and you've got that idea in your head, you can in fact work back to anything. Lines radial peripheral, I'm going through this very quickly. We see them in melanomas, we see them in Spitz-Nevi, but of course lines radial peripheral that meet at a point we'll see in basal cell skin cancer. Lines curved, you're going to see in these various, this is just because of the arrangement of keratinocytes and the pigment that's in them. Sometimes they'll look lines curved like this, and it's mainly solar lentigo and seb-Ks, but these others can have it too. Lines branched, they're not at right angles. The classic is the ink spot lentigo, as you all know, but sometimes you'll even have little lines retic associated with an ink spot lentigo as well. Lines parallel furrow, you know that in the palms of the hands and the soles of the feet, you're going to see the pigment in the furrows there. The ridges are the thick bit, and the pigment's going to be in the furrows, and that's in the picture of a normal acral nevus. Whereas if you go to a melanoma, different picture altogether. All the pigment then is in fact in the ridges, and you've got the thick ridges pigmented there. So lines parallel ridge is virtually always a melanoma, except if you've got a bit of hemorrhage, which will do the same thing. Dots, they can be a variety of colors, and again, they're usually due to melanin or small little nests of melanocytes. The classic is the gray dot that you'll see in LPLK. Clods are globules. They're bigger than a dot, but varying in size and color. And the different colors you're going to see are going to be whether it's melanin that's making up those, whether it's thick nests of melanocytes that are going to give you brown if it's at the dermoepidermal junction and black if it's higher up in the epidermis, or whether it's going to be keratin filling in crypts in the surface of seb-Ks, and where it's going to be white or going to be yellow. So color is going to vary. And of course, in a hemangioma, going to be nice blood-filled clods that you're going to see. Circles, We discussed how circles are forming in that previous one, but in the face, you often have a very flat basal layer. You don't have extensive retiridging. And a lot of what you're seeing in the face are due to the openings of the infundibula of the sebaceous glands that are there. And it's the arrangement often of cells round about the openings of that infundibula that will give you your gray circles or the dots in pigmented solar keratosis. All of these we're going to be showing with histology later on. Pseudopods are just the thickened ends of lines radial peripheral. And generally, they indicate a very actively growing thing. Structureless areas, I always have trouble with structureless, because there's nothing in it, I suppose. But Cliff always can see the significance of structureless areas much better than I can. But the classic structureless one is the blue structureless thing of a blue nevus. White lines. Cliff has done a great deal of work on these recently in pointing out to us the significance of these. And you're seeing them now in BCCs, melanomas. You need polarizing light to show them, but it's intersection, often at right angles, of collagen fibers in the dermis that can be part of the scaffolding of a melanoma or part of the basic structure of a BCC. Polygons, this was Jeff's work. These angled, 3 to 5 sided angulated structures, particularly seen off the face on the back of all his Ballina patients that have these lentiginous melanomas. It's been a very good marker for us to know which lesions to shave and to look at. So polygons, that's what polygons are. Vessels you'll see in quite a few presentations today, and they're important obviously in melanoma, amelanotic melanoma, but they're also important in BCCs and also important in some SCCs, particularly the ones in situ with the coiled vessels. So again, this is the work of Cliff and Alan Cameron with the terminology that's there as their terminology for describing vessels and the pattern that those vessels take. So these were just some examples on the left here of the coiled vessels of an SCC in situ, and on the right, the polymorphic vessels, but not enough. There should be, normally there'd be a few more dot vessels along with those polymorphic vessels in an amelanotic melanoma. And in the end, it's all down to correlating dermatoscopy with dermatopathology. And if you look at this lesion here, you see these white things here, and you might have thought they were in fact going to be milia. But when you get the slide back, you see that it is a BCC, but you've got blue staining stuff here. What did I say will stain blue as well as the nuclei and the stratum granulosum? What else will stain blue? Calcium. Well done. So there's a bit of calcification within that cyst there that's giving you the white dots that we're seeing there. So that's just a very rapid overview of some of the terminology in pathology and some of the terminology in dermatoscopy. And all of this is going to be expanded on by the various lecturers throughout the talks we're going to have this weekend.